Hello, everyone. My project is titled How Acute Care Environments Shape Family Stress, Coping Behaviors, and Communication Experiences. My research question focused on understanding how two distinct environments, the cath lab waiting room and an ICU patient room, influence the emotional well-being and interactions of patients and their families. I chose this community because of a deeply personal health event. My mother underwent a cardiac procedure that resulted in complications. This experience gave me a unique vantage point to explore how these high-stress clinical environments shape family stress, coping mechanisms, and communication experiences. My goal was to compare the passive experience of waiting with the active, high-intensity experience of acute care. In the waiting room, I observed a diverse group of about 10 to 12 adults, ranging from their 30s to 70s. These were primarily family members, spouses, and adult children waiting for news. In the ICU, the demographic shifted to a micro-level interaction involving three key players: the patient, my mother, an ICU nurse, and a neurologist. The observations took place on November 17th, 2025, at Scripps Memorial La Jolla Hospital. I spent time in the waiting room at 3:42 p.m. and later in the ICU at 7:40 p.m. My field note approach was strictly observational. I focused on recording sensory details like lighting, sounds, and smells, and physical cues of stress, such as posture and movement. For my data analysis, I used a thematic approach to identify patterns in coping behaviors, the environmental atmosphere, and the contrasting communication styles of the medical staff. In the waiting room, I identified what I call a ritual of anxiety. The atmosphere was defined by suspended time. I observed specific coping behaviors: intermittent phone scrolling, slow pacing, and fidgeting. There was a collective avoidance. People rarely made eye contact, perhaps to respect privacy or hide their own fear. One interaction really stood out. A man on the phone says, "When are you coming? You were supposed to be here already?" This moment really captured the collective tension of the room, where even routine procedures carry the heavy weight of fear. The ICU presented a stark contrast. The atmosphere shifted dramatically. Unlike the quiet waiting room, the ICU was charged with immediacy. It was a space dominated by technology, the rhythmic beeping of monitors, and the smell of antiseptics. Sensory details included bright fluorescent lights, the rhythmic beeping of monitors, and the distinct smell of antiseptics. A key finding here was the difference in communication styles. The ICU nurse was gentle and grounding, frequently using reassuring words and explaining her actions. In contrast, the neurologist was sharp and distant, focusing entirely on the monitors rather than the people. This contrast significantly impacted the emotional tone of the room. The ICU presented a stark contrast. The atmosphere shifted dramatically. Unlike the quiet waiting room, the ICU was charged with immediacy. It was a space dominated by technology, the rhythmic beeping of monitors, and the smell of antiseptics. Sensory details included bright fluorescent lights, the rhythmic beeping of monitors, and the distinct smell of antiseptics. A key finding here was the difference in communication styles. The ICU nurse was gentle and grounding, frequently using reassuring words and explaining her actions. In contrast, the neurologist was sharp and distant, focusing entirely on the monitors rather than the people. This contrast significantly impacted the emotional tone of the room. Reflecting on this study, what matched my expectations was the general tension in the waiting room. The universal signs of stress, like foot tapping and clock watching, were exactly what I anticipated finding. However, what was most surprising was the sheer speed at which the environment shifted. The sudden realization that my mother was having a stroke changed my observational lens from academic to terrifyingly personal in an instant. It showed me how quickly the role of family member overrides the role of researcher. Regarding the methodology, I found observational research challenging. Being a passive observer, especially in the ICU where privacy restrictions anchored me to one spot, felt limiting. Comparing this to other methods like interviews, I realized that observation captures behavior in real time, which is powerful. Body language can speak so loudly without saying a word. However, unlike interviews, observation didn't allow me to know what other families were thinking. only what they were showing. I couldn't ask them why they were pacing. I could only note that they were pacing. This fieldwork taught me that acute care environments are not just clinical spaces. They are profound emotional and social spaces. On a personal level, this was a difficult but enlightening process. Observing my mother's care highlighted that in moments of crisis, communication is a form of treatment. The nurse's steady voice served as an anchor for me and my mother. For future research, I would recommend conducting qualitative interviews to understand how families cope with unknown wait times. I also think it is crucial to investigate the emotional labor of nurses, who are the bridge between the technical and the human sides of care. I will take this lesson with me, that how we speak to patients is just as vital as the medicine we administer.